With kind permission of my mentor, Professor R.R. Koiri sir, at the beginning, I want to extend my thanks and gratitude uh, to the organizer of our POSB, those who are working hard and dynamically managing uh, this webinar at weekend. And this is actually keeping the educational wheel running or moving and making us enriched with updated knowledge on the subjects. And we are all learning and taking part and enjoying also. And thanks to our Sarwar Ibn Salam, our dynamic secretary, who is very active and enthusiastic, and he's always trying to do his best for this webinar. I want to remember the name of our beloved Shamirul Islam Babu, who has left us with a lot of memories with him. I will not mention everything, but this COVID-19, I think it has destroyed all our dreams, all our hopes prematurely to many of our colleagues. And already many of our teachers and our doctor fellows and other peoples, they have laid their lives in COVID-19 infection. And many, many peoples in our country are suffering. I'm praying those who have left for their soul to the best place in heaven, and those who are suffering at this moment, they should be come around very soon. I'm praying for them. And with these talks, I want to start my topic, pediatric hip fractures. As I want to thank Noman, he has mentioned many things, but I am not that. I am just following Professor Koiri sir, and the way he is working, I am following this route, like that of a successor or apprentice. Pediatric hip includes proximal femoral epiphysis, neck, and trochanter. We all know, and no one has already mentioned these are rare fractures. Rare condition and incidence is less than 1%. Very high rates of long-term complications demand early aggressive treatment. This is the complication what draws all attention of our orthopedic and pediatric surgeons, and which demands very early treatment and aggressive treatment with all efforts. Always poses the problem of compliance between parents and surgeon regarding the treatment. I have added this subject because parents always ask the surgeon that very simple trauma, very simple injury, but you are asking for general anesthesia, open reduction, closed reduction, and many, many things. This is the problem posing between the counseling, and long-term outcome also poses another problem for the surgeon to convince the parents. If we go for etiology, proximal femur in developing bone is very highly resilient and stronger, we know, and fracture results from high velocity trauma in 90% cases. And common causes are fall, not fall from a standing height, it is a fall from a roof, fall from a tree, commonly occurs in our country, motor vehicle accidents. These are also common nowadays in urban areas, and sports injury also. On the other hand, low velocity trauma can cause fracture in weaker bones. This is only 10%. Pathological fractures like ABC, SBC, metabolic bone disease like rickets, hyperparathyroidism, osteogenesis imperfecta, and other two factors I have mentioned, faulty delivery and child abuse. These two can occur in normal bone but with minor trauma. Associated injuries, these are as high impact injury causing the fracture. These injuries combines almost 30% injuries to the other parts of the body. The common sites are head injuries, abdominal visceral injury, chest trauma, and other limb injury, as well as pelvic injury also. So, to manage these patients, standard trauma protocols, ATLS, like primary survey with resuscitation, secondary survey definitive care should be followed. And the specific care for the hip fracture should be started only when the patient is stable hemodynamically. Neonates and infants have a greater tendency to hip dislocation or fracture dislocation because of plasticity of the cartilage and ligaments. Pediatric hip fractures demands early care and adequate facilities. In every condition, surgeons should be alert and prompt to their response regarding care, and these facilities should be available, like anesthesia to the pediatric group of patients, fluoroscopic facilities, and OT facilities, frequently associated with serious complications. Somebody told dreaded complications. No one has also already mentioned. Somebody told disastrous complications. Most commonest is the AVN. And next one, varus with non-union or malunion, premature facial closure with LLD. These are the most common complications. Some factors we can control, but AVN we can do very little. Almost all fractures require early operative treatment. So this is a fracture of necessity. I want to pay attention to the developing femoral head and also the blood supply to the femur. This is a most important topic, I think, and relates with the prognosis of the patient. This, as the head of the proximal femur of the child develops from, we can evaluate it from 0 to 4 months, 4 months to 4 years, and 4 years to 18 years, and next 18 years. All the understanding of blood supply of developing femoral head helps in evaluating the results of treatment. Trueta in 1950, later Osden, they have described in elaborately the evolution of the femoral head. Here I want to mention that at birth, the proximal femur almost whole is a cartilaginous piece of bone, and at 4 months in female and at 6 months in male, the ossific center at the capital femoral develops, and later the facial cartilage grows, and at 4 years the facial cartilaginous growth becomes complete. So here I want to mention there are some vessels, transosseous vessels, when the facial plate develops, that it creates some barrier to the facial plate, and the transosseous supply gradually declines. So there develops a vascular compromise in this situation. I will describe in the next slide. This is my favorite picture of Nature. This picture on the left hand side, this is the adult femoral supply. We first mentioned how the femoral head gets its supply normally in adults. In adults, we know the medial and lateral femoral circumflex, these two vessels, the medial and lateral femoral circumflex arteries, they supply through the retinacular branches and also through the metaphyseal branches in the adult and also in the child before the development of the facial plate of cartilage, that is up to 4 years. And this is the reason there are some infection in the metaphyseal plate can goes to the, metaphyseal area can goes to the joint. That means the osteomyelitis can go through septic arthritis. But when the facial plate becomes complete at 4 years of age, there are no transosseous supply. Then the supply only depends upon the retinacular vessels. And retinacular vessels also have some changes or evolution. This picture I have taken from Tagjian. You see here, this is the medial circumflex artery. This is the main supply in a developing femoral head after 6 months. These retinacular vessels takes the shape in this way. In the group between the deck and the trochanter, the medial circumflex femoral artery arises as the posterior superior and posterior inferior group of vessels. They travel along the retinaculi and jumps over the perichondral ring and supplies directly to the epiphysis. At the beginning, both the medial and lateral circumflex vessels supply equally to the anterior half supplied by the lateral circumflex artery, posterior half by the medial. But as the facial plate grows, as the neck rapidly grows at 3 to 4 years of age, and neck shaft angle increases, in the book it has been written that this medial contribution, from the lateral circumflex femoral artery falls short and they cannot contribute to the head. On the other hand, it solely depends upon the lateral epiphyseal vessel, which is from the posterior superior and posterior inferior group from the medial circumflex artery, and the artery to the head of the femur or ligamentous teres also contributes very little. So this blood supply becomes tenuous after 4 years to 18 years. After 18 years, this epiphyseal supply again from the lateral circumflex artery regains, and also uh, there forms a anastomotic ring between the medial and lateral circumflex artery, and through all around the perimeter, the supply becomes normal. So the jeopardized age is 4 years to 18 years. This is the age of concern, as the child fractures are common in this age. So the complications like avian and other factors happens in this age. Let's go for diagnosis. Diagnosis is not very difficult. We all know there is a history of high velocity trauma, and symptoms may be inability to move the limb. Baby cannot move the limb at any attempt. Pain in the inguinal area and may spread to the knee. The signs, the limb is flexed, externally rotated and abducted. This is the common, but if there is any dislocation, it may be flexed but internally rotated and adducted. Movement is restricted, as I mentioned, and shortening may be there. In infants, if there is non-traumatic hip pain or pseudoparalysis, there should be a look for any septic hip problem or any transient synovitis or DTAs. The mainstay of diagnosis, radiology is the mainstay of diagnosis. X-ray epi view of both hip joint for comparison with the healthy sites. It should include the knee joint and pelvis also, to see any other associated injury on the other parts also. Cross-table lateral view of the affected hip. This is advised. We commonly advise for frog leg lateral view, but here the cross-table lateral view advocated because it can cause, frog leg lateral view can cause some extra displacement and pain to the patient, which is cumbersome. Other modalities of diagnosis, the arthrography. Arthrography in neonates can help in differentiating when there is a confusion between DDAs and the dislocation of the femoral head. Ultrasound is also helpful in diagnosing the DDAs, and sometimes if there is any confusion with sepsis or any trauma, we can aspirate. Ultrasound guided aspiration can tell us whether it is a hemorrhagic fluid or turbid fluid of infection. MRI can help in cases of sleeve capital femoral epiphysis, undisplaced fractures or impacted fractures or stress fractures. Besides this, we may need to go for to assess the femoral head viability by MRI. Sometimes in most of cases, if there is any metallic implants there, we may need to go for bone scan and CT scan also. Now comes to the types of the fracture. Delbert's classification. This is a worldwide accepted classification, and recent classification systems of AO groups, they have also accepted these classification types. Very easy to enumerate, very easy to recollect, and it correlates with some frequencies of complications, especially avian. Delbert type 1 is the transfacial or transepiphyseal injury, which are subdivided into without dislocation, type 1A, and if there is dislocation, type 1B. Another type is transcervical. Third type is cervicotrochanteric or basicervical. Fourth type is intertrochanteric. These are also subdivided into displaced and undisplaced groups. Treatment. Overall treatment outcome depends on the types of fracture. This is very important, and amount of initial displacement, timing of surgery, age of the patient, and modalities of treatment. The type of fracture, the initial displacement, and age of the patient we cannot control. It is called unmodifiable factor. But timing of surgery and modalities of treatment, these are called modifiable factors. We can control these factors. Historically, spica was the mainstay of treatment for pediatric hip injuries. But only hip spica turns into some unacceptable complications. So all studies support use of hip spica as an adjuvant of internal fixation. Child can tolerate hip spica much more readily than adults. I've taken this picture of a comfortable child. This is some 30-degree abduction and some degree of flexion, 20-degree, and comfortable knee position. Sometimes in non-compliant child or highly active child, we have to include up to this part, knuckle of the toes. And 1.5 spica is enough for immobilization. Now comes to the individual fracture treatment. Transepiphyseal fracture, the incidence is very low, only 8%, but complication is very high. So we are fortunate that this type of fracture is called highly complicated fracture. 1A can be treated if it is undisplaced. Only hip spica is enough. But if it is displaced, close reduction and hip spica should be given. If the child is less than 2 years, only hip spica is enough. But if it is more than 2 years of age, then some sort of internal fixation should be used. And type 1B, if it is a dislocation, in some books, one attempt can be done to reduce it, but some books says you should not go for any attempt of reduction. Straightforward go for open reduction. If it is a posterior dislocation, modified Gibson approach or safe surgical dislocation by Dunn technique should be followed. If it is an anterior dislocation, Watson-Jones approach is advised. This is a book picture, not mine, because I have not yet come across this type of fracture after the Debnath type 1 fracture. The guideline is close reduction under GA, fluoroscopic facilities, and gentle traction, extension in abduction, and internal fixation. Regarding fixation, internal fixation done by smooth or threaded K-wires in a young child. I mentioned if it is less than 2, no need for internal fixation, but if it is more than 2 to 4 years, between 2 to 4 years, K-wire, smooth K-wire is enough, but more than 4 years, 4 millimeter cannulated hip screws can be used. Outcome of type 1 treatment fracture. Child's less than 3 years, ABN is less if it is undisplaced. I mentioned during vascular supply, at up to 4 years of age, the femoral head has surplus blood supply. It gets its supply from 4 sources, I have mentioned already. So ABN is less in this age group, but type 1B has an incidence of almost 100% ABN. Some books 70%, some books told it is 100%. These fractures are very rare, but may confuse with slip capital femoral epiphysis. These are displaced fractures, sometimes confused with it is a saltative type 1 injury, and sometimes it is confused with the slipped capital femoral epiphysis in adolescent groups with minimal trauma and repetitive trauma where it occurs. Iatrogenic physeal separation may occur during forceful reduction of a dislocated hip. If we forcefully try to reduce a dislocated hip, we can cause a iatrogenic fracture, type 1 fracture of proximal femur. I have faced some problem, and I tried to mention and try to pick this problem. You see, this is a big adult fracture table. I think everywhere we follow this table, and this pubic post always poses some problem for adduction. If we need to adduct the thigh in a small thigh, it's very problematic, and it needs some reduction. And this long bar, this bar is also this bar causes sometimes the short limb and long bar and long foot. We have to add some wooden block or something else to give traction. This is a problem I have added. If somebody else have any small fracture table for pediatric age groups, I want to know where it is available. Next, come to the type 2 fracture. This is a most commonest fracture, and everyone face this problem. It is 45 to 50% incidence. Tuxian's pediatric orthopedics, it has mentioned that all transcervical fractures, whether displaced or undisplaced, in children of all ages, be treated by stable internal fixation to avoid subsequent loss of reduction, malunion, delayed union, or non-union. This in Campbell it also mentioned, because we know this fracture type. They have told that in the children, this fracture causes a monoplanar fracture. Fracture occurs in the single plane, and this serration, though it is graphically shown, but serration is not available. In case of adult, it is possible. Serration helps in stabilizing the fracture once it is reduced, but in case of children, it is a smooth single line fracture, so displacement is common. And fracture line along with the Powell's angle, this is also important. And the more horizontal the fracture line, the more stable. The more vertical the fracture line, more it is unstable. Another problem is here. This boy of 8 years, transcervical fracture with minimal displacement. It was very nicely reduced and fixed with two 4 millimeter cannulated screws, one with washer. Neck shaft angle is nice, and you see in 9 months healing is. This is during the time of removal of the screws. Internal fixation. How we will fix it? Uh, Under general anesthesia and fluoroscopic guidance uh, for reduction is mandatory, and it should be done by following Whitman's technique on a fracture table. Whitman's technique, I will mention very shortly. That is, fractures usually proximally migrates the trochanteric area. At the beginning, fracture should be given traction in extension, and this fracture fragment should be being brought back to single line, and then abduction to disimpact it, and then internal rotation. And at this point, there's some external pressure over the trochanter they have advised in the book. This is the Whitman techniques maneuver for closed reduction. It should be tried once or twice. Once the closed reduction fails to achieve an anatomical or near anatomical reduction, we must go for open reduction. We must not hesitate for any open reduction, because closed reduction and open reduction gives almost equal result. There is no added complication. Here, there are pictures of two screws I have mentioned. These two are, we know, everybody, we know this is the 4 millimeter cannulated screws, and these are the nose pins. I've seen Sir was fixing it about 20 years back. Nose pins, 2, 3, or 4 nose pins for fixation, but these are not nowadays not used. This is a review article where it has mentioned that implant choice. How we can choose the implants. If the baby or patient is less than 4 years, smooth or threaded pin is advised, because for these fractures, too often we need to go for penetration of the facial plate. If the baby is 4 to 7 years, 4 millimeter cannulated screw advised, and it is a maximum, not minimum 2, maximum 2 should be given, not more than this. But more than 7 years of age, you can give 5 millimeter or 6.5 millimeter cannulated screws. But in spite of this suggestion, hip spica is a must. It should be given depending upon the age for 6 weeks to 12 weeks. If closed reduction fails, open reduction is advocated, as I have mentioned. For open reduction, we always prefer this Watson-Jones approach. It is a favorite approach of me, and Sir also do it. I have learned from him. Watson-Jones approach, we all know the incision, but I want to mention here this is the plane. Anteriorly, the tensor fascia lata is tensor fascia lata muscle is anteriorly, and at the back the gluteus medius. And when we retract it, this iliofemoral ligament is visible, and this is the upper margin and lower margin. We can open this capsule by L-shaped incision or T-shaped incision, but to give the T-shaped incision, we must be aware of these vessels. Here the lateral superior epiphyseal vessels here, and here the lateral circumflex femoral main trunk is here. So we must be cautious about this. And I have mentioned, I've taken this picture of mine to open this femoral neck here. I have used 2 lever, bone lever. In the book, it has been written that we must not use it because this pressure can damage the dentacular vessels. So it can cause harm to the vascular supply to the head. They have advised a reverse smooth retractor like that of mastoid retractor, but smooth blade should be there. Another problem is here. We have to put the patient on a fracture table and to see the lateral view nicely. But in a fracture table, the Watson-Jones exposure is difficult because in extension the capsule becomes tight and it becomes very difficult to. So I usually do it. I have seen that in the normal table, but in normal table, lateral view is not comfortable. I have added few slides and debates whether crossing or not crossing the plate by implant. Why this is a concern? The proximal femoral physis contributes 15% of the total length of lower limb and 30% of the femur, and increases at a rate of 2 to 3 millimeter in length per year. And premature fascial closure, if we do damage, any damage to the fascial plate, that can lead to the LLT. So in the book and in the article, they have mentioned that if the patient is more than 9 years, cross the physis for fixation, because we must not compromise the stability of fixation to save the fascial plate. And if the child is less than 9 years, single smooth pin, if at all if you need to go through the fascial plate, a single smooth pin can be used, or threaded screw can be allowed at the center. Other screws should be at the metaphyseal area, should not cross the fascial plate. Another debate whether we should go for any preoperative traction till the patient is taken to the operation table or reduction table, and hip decomppression. Position of ease, flexion, abduction, and extension, external rotation allows maximal intracapsular space. So once we give traction, it reduces the kinking of the capsular vessels, and that can open up the blood vessels, but increases the tamponade defect that can add. So there is a controversy whether should we go for any traction or not. They have advised keep the limb upon a pillow in a comfortable position. That is a good position. And somebody told that you must not go for any added traction. And another question is drainage, whether we should go for drainage. Most of the authors, they have given the opinion drainage helps to reduce the tamponade effect, but it should be within 48 hours following the injury. And anterior drainage or subadductor drainage can be given, or needle aspiration with a wide bore needle can be done. Another debate, number of screws, how many screws we should use. In a biomechanical study, they have shown that one large screw gives 70% strength, and 2 screws gives almost 100% stability in a child. But if the child is older, it should be 3 screws there. Smooth pins don't cause any fascial damage, but this pins can protrude through the joint as there are no backout mechanism. This smooth pins also have a problem to penetration of the joint. Let's come to the type 3 injury. This injury is less frequent, but second most common, 34% in prevalence. Fractures are partly intracapsular and partly extracapsular, so the incidence of AVN is less. Here the incidence of AVN is 18% average, and whereas non-union is more common. This is called basicervical or cervicotrochanteric. What are the options of treatment? Undisplaced fractures, if the boy is or patient is less than 6 years, we can treat it by abduction, spica, but we should have a cognizant follow-up. Cognizant, I have mentioned that word, that every weekly should be checked. If there is any loss of reduction, if there is any displacement, then you must go for open reduction. Above 6 years, open or closed reduction followed by internal fixation with sliding hip screw or side plate is advised. Why side plate? Another article, analysis of risk factor for complications after femoral leg fracture in pediatric patient. This is a recent article, 2020. Reduction postoperatively evaluated if it is less than 4 millimeter, that is a step up at the fracture site. I have missed that word. If it is less than 4 millimeter, that is good reduction. If it is more than 4 millimeter, bad reduction. Angulation, it is more than 5 degree, less than 5 degree, that is good, but more than 5 degrees is unacceptable. And next shift angle, once it is less than 120 degree, it is called coxa vara. They have mentioned that once core reduction increases the approximately 34 times the possibility of developing coxa vara. This is another patient. I picked it up from SAR. 5 years of 12 years boy. This is a Delbert type 3 fracture. It was reduced nicely and fixed by 3 screws. But you see, sorry. You see, there are shortening of the neck and neck shaft angle also lost. So in this type of fracture, as the distal purchase is smaller and metaphyseal length is sufficient, so crossing or not crossing the facial plate is not a problem, but here side plate should be given to avoid the varus deformity. Tips and tricks. I have added the picture. The tips and tricks. Pediatric femoral neck is very hard to drill and generates high amounts of torque. This torque occurs in the proximal fragment. To prevent this, at least 2 K wires should be kept in position while we are drilling one guide wire. Tapping is a must to prevent the impaction of the screw, and multiple drilling at the base of the trochanter may cause iatrogenic fracture at the base of the neck. And they have also mentioned that distal part of the screw should be over drilled to provide the compression mechanism or lag mechanism. Type 4 fracture, it is less common, 12% only, and high velocity trauma needs to break this strong bony area incident, but pathological fractures are more common in this area, as I mentioned earlier: bony cyst, fibrous dysplasia, OI, metabolic bone disease. Close reduction with hip screw or sliding hip screw or side plate fixation is always successful. AVN is very less in this group. I have mentioned 2 pictures of my cases. This patient, 8 years boy, presented with a cystic lesion with pathological fracture and varus deformity. I have operated it. I have fixed it with a pediatric hip screw and simultaneously valgus osteotomy I have done. This is Parvati picture. And in the below, after 6 months, the healing is nice, but neck shaft angle is some degree of varus is there. But healing is. Another patient, this boy presented to us with a fracture in the trochanteric region, but the trauma was very unrelevant, very minor trauma was there. So we thought that there should be a cystic lesion, and actually there was this solitary bone cyst. I have fixed it. Here I have been able to maintain the neck shaft angle, and healing achieved within 9 months. Complications. Let's come to complications. We are all concerned about the complications. AVN is the most commonest one. Varus malunion is another, and premature facial closure. This is also in some books. It has been written that 30% cases varus malunion and non-union also. This varus malunion, non-union, and premature facial closure we can manage. We can manage the patient, but AVN, that gives the lifelong morbidity, and it is enough to defame any good name surgeon. Infection is also another complication, but it is there in the hip. Incidences of AVN, Delbert's type correlates with the incidences of AVN. Earlier, the incidence was almost 100% in type 1 fracture, but now it is 38%, and subsequently type 2 is 28%, type 3 18%. This is an average picture. Type 4 is 5%. At the below picture, I have shown a few pictures of Whitleaf's classification of AVN. This is a type 1 classification. We found that the medial circumflex femoral artery, if it is damaged during the initial trauma, the global necrosis occurs, and this involves from the fracture line to the up to the head. And this type 2, this sectorial or a small area can be involved if only a posterior superior group is involved and other groups are viable. This is a metaphyseal or neck necrosis type 3. This usually results from the injury to the lateral circumflex femoral vessels. What are the modalities of treatment of AVN? In the book, it has been written that we must keep, once the AVN is significant or evident, as the patient will complain pain within 2 to 3 months of fixation, and then at 7 to 20 months, the radiological picture may be obvious, and then the patient should be asked for partial weight bearing or non-weight bearing, and some amount of abduction spica can be given at night. We can do early implant removal. As soon as the AVN is suspected, implant should be removed, and other modalities of treatment those are core decompression. They have advised some derotational osteotomy, mostly valgus osteotomy or other types of osteotomy they have advised, and some osteotomies of acetabulum like that of Parthis they have advised in the book. Osteosynthesis by vascularized fibular graft or non-vascularized fibular graft, muscle pedicle bone graft, these are also advised. About 20 years back, Sir used to practice muscle pedicle bone graft, and Samasar also did it. I accompanied them. But nowadays we are not practicing musculoskeletal bone grafts. This is a research article. They have mentioned that reduction later than 1 day or 2 days doesn't affect the incidence of AVN. Even after 9 days, this is a Chinese study. 9 days study shows there was no AVN. But it doesn't mean that we should wait for 19 days. We must do it. They have shown that they have done the operation within 4 days on an average. Children younger than 9 years, epiphyseal penetration may develop PPC, proximal premature facial closure. These are my patients. This is an adolescent girl of 16 years. She presented to me very undisplaced fracture. This area, impacted fracture. I have fixed it. This is 3 months after fixation. The bone was healing, but after 6 months, I have seen some amount of uncovering, and here is the depression. And after 1 year, you see the AVN is developing, and this area is developed. But the implants was removed later. I think the implant, delayed removal of implant may be the cause of this AVN. Another patient, this is SARS patient. I have taken it. This girl also 17 years, the comminuted fracture at the neck. Probably this is the fracture specific. AVN is the fracture specific complication, and the initial amount of trauma, amount of displacement, that determines the AVN, not the sudden. You see the head shape has been changed and deformed. I think it's globally involved, and neck also shortened, but union is there. These are good. These prognoses are good. Another patient, 11 years, I have done it in my hospital. I have accepted a compromised reduction. Compromised reduction here. You see 3-4 millimeter cannulated screws I have applied, but there are some step up. After 9 months, you see the global AVN is there, and implants were removed later on, but we could not do anything. This is another patient. I have taken the pictures from SAR. One of our senior colleague, he had done it at 3 months. There was cut out, and after that, the screws were removed, and how the varus was developed, and atrophy was there. So we have done it to restore the revive the femoral head, a fibula restored graft, and valgus osteotomy, and subsequently simultaneously subtrochanteric valgus osteotomy. We have done it, but I cannot show you the follow-up due to corona. Probably follow-up is with SAR. I have taken this slide for valgus osteotomy. I used to do valgus osteotomy. I have done for 6 to 7 cases in my hospital. This is Powell's valgus osteotomy. Basic is the Powell's valgus osteotomy. If we improve the angle from this angle to that angle, it changes the shear forces into compression forces that helps in non-union, and also add some height. This is the delta H. This is the height. How they have measured? This is a geometrical calculation. Height is length is fixed. This point to this point length is fixed, but once we change the angle, that we can achieve some height. So if we do some valgus osteotomy, if we cut some area from here, subtrochanteric ways, we resect it, we do not add any harm to the patient. We do not add any shortening to the patient. And how do the base of the segment or waist should be measured? This is a tangent of the angle with the diameter in millimeter. And in the book, it has been shown, and there are charts we can easily find by this formula, 0.2 into diameter of the bone and desired angle. This can. These are the plates the Powell used, double angle blade plate, but nowadays these plates are now used. These are the fixed angle blade plates and locking heads, but we are not using this. We are using these pediatric hip screws. These are available at different angles, 35, 30 degree, 45, 50 degree even. I am using these blade plates. These are my few patients. These complications I faced. One screw was given, but it turned into a varus with non-union, and I have used this this fixation with the Powell's valgus osteotomy and pediatric hip screw. At 1 year follow-up, this is nicely healed, and child of 10 years, he can walk well. Another patient with a non-union, this was done in Pabna. This fracture was fixed more or less nicely, and there was varus. So this is a question of side plate fixation has come. So I have operated it, and I have turned into a valgus osteotomy, and which I have resected. And latest follow-up I cannot give. This is a 6 months follow-up, and now the boy is walking nicely. This is a stress fracture. This operation, I have followed this child of 12 years, Ramisa. She presented to me initially with this stress fracture. I advised them to go for surgery, but they denied. Later on, after a few months later, about 10 months later, they came with this situation. This is a stress fracture. Sorry. Yeah, this is a stress fracture of unknown cause. In the book, it has been written that repetitive trauma or army recruit, they can cause weaker bone or any osteomalacia or any rickets. There might be a stress fracture. There are two different type of stress fracture. I will not go there. I have fixed it, and some amount of valgus I have restored, and this baby is nicely walking. I'm coming to the last slide. This is my last slide. Conclusion. To reduce the incidence of complications, we should perform urgent reduction based on the child is hemodynamically stable due to other traumas. Surgeons should try their best to achieve anatomic reduction and be cautious about the fascial penetration. Parents must be informed that the AVN is related to the nature of the fracture rather than the type of the treatment. It is the fracture specific, not the treatment specific. So AVN, how it can come, we cannot see. Thank you, everyone. Thank you for patience hearing.
Thank you, Dr. Shamal sir. I have some questions in the chat box.
Okay, fine.
First question is from Dr. Tasriful Alam to Professor Shamal sir.
Yes.
How can you classify pathological fracture and stress fracture in pediatric group of patients for proximal femoral fracture? It can be classified by Debnath classification?
Debnath is a traumatic classification, but there are type 4 fractures. These areas most commonly, as I have mentioned, the 10% cases, the pathological conditions can cause this fracture. Debnath has included these pathological fractures also in their pediatric hip group of injuries. And stress fracture is a different entity. Stress fracture it is not due to the violent trauma or high velocity trauma. It is a minor repetitive trauma that precipitates the cause if the bone is fragile or if the bone is strong, but the trauma is new recruit like that of army recruits or any exercise, unaccustomed exercise that can cause the stress fracture. These stress fractures are divided into two types: the tension type, if it is the stress fracture is superior part, and the compression type, it is the lower part. In compression type, it has been mentioned that you need not to go for any fixation or anything else. Only immobilization is enough. But if it is a tension type, it can progress. It can turn into a varus, and you must go for internal fixation.
Professor Kori, do you want to say anything?
I think it is well explained. The stress fracture is not included in the Debnath type, but Shamal has explained that
No, different entity.
It is different entity, and this classification or this description is very important. Where it is fracture is on the superior part or inferior part. Either it is a sharing type or compression type.
Right.
The compression type will heal, but sharing type may heal, but there will be varus. That is called problem. We have seen this stress fracture in our female recruits, cadets nowadays, in the cadet college or the girls cadet college and in the army recruitment and in police recruitment also. So previously it was not common, but nowadays the girls are recruited in the army and the police, so this incidence is increasing stress fracture.
But that is
Next
extremely
question.
rare, sir. For neck fracture, stress fracture of neck is extremely rare, sir.
Yes, rare, but we
Rare.
get it with
Very common.
rare injury. But we
So
now that the incidence is increasing, I am saying that because these new recruitments of the females in the army, and in the police. Rumel, you want to add anything? No. Go to the next question.
next
sir.
question.
We can go to next
So,
question.
next question is from Dr. Saiful Islam. He want to know specifically about the pediatric BHS and Knowles pin regarding the management of pediatric hip fractures. And he also want to know how we can prevent the breakage of Knowles pin during its insertion.
Saiful, I want to mention that it was practiced 20 years, almost 20 years or 15 years back. Nowadays, we are not practicing because these pins, nose pins, doesn't allow any guide wear or any guidance. And nowadays, more advanced cannulated hip screws are surgeon friendly, and you can rightly put it at your targeted point and without any complication. So nose pin brace is a problem that is mounted over the drill and straightforward put within the strong bone. Sometimes it can break, and removal is also another problem. I have faced this problem. To remove the nose pins, there is no slot like that of our hexagonal slot of normal screw, AO screws. So this is another problem. We have to use the pliers or vice grip or anything else to remove these nose pins. So for these reasons, we are not using the nose pins nowadays. But these are strong pins, and it is mentioned in the book 3 to 5 pins can be given in a fracture for fixation. These are the stories of earlier days. And another question is dynamic hip screw. How can I use the dynamic hip screw? I use the same principle as I put the guide wire in the adult fractures, fracture neck or fracture trochanter, as I put it. But caution is I put at least three guide wires in position, and 2 guide wires should be in position to prevent the rotation of the proximal fragment. Because once you put the reamer, it generates a lot of forces which can rotate. The reamer can rotate the head or proximal fragment along with it. So to prevent it, you must have to be cautious whether it is changing the position or reduction is losing, and then you must be cautiously give it. And don't cross the facial plate with a dynamic hip screw, pediatric dynamic hip screw, because it will cause this lot of damage and it will damage the facial plate altogether. So there will be definitely premature facial closure. So in cases of adolescents and more than 8 years or onwards, we can use the pediatric hip screw. But if a younger child, you must have to keep yourself in cannulated hip screws or leg screw devices. Thank you.
So Dr. Ghulam Farooq is raising his hand. Sir, do you say something about
Yes. Thank you, Shamulda, for a
you,
beautiful
sir.
and nice, resourceful presentation. You have a lot of reference here. I have a question to you, also Professor Koiri, sir.
Yes.
In case of fixation with a screw above the 9-year-old child, you mentioned that we can cross the facial line with the all screw or a single screw here. If you put 2 screws, all the 2 screws should cross the facial line, or single screw cross the facial line and not another one. Number 1, it is my first question.
Okay. Should I answer?
Yes, of course.
Okay, sir. 9 years is a age limit, age cutoff line. After 9 years, the remaining growing age is, if it is 18, if it is 18 or 16, say 16, 6 years. 6 years, 2 millimeter per year, 12 millimeter. Remaining growth is 12 millimeter. It is estimated. We can accept 1.5 centimeter or 15 millimeter. But we can adjust it. Can you remember? I want to mention Kazi Shahidul Alam sir. Sir told that জুতোই ঠিক করে দিও, যেটা বাংলায় বলতো আর কি, খুলনার ভাষায়, হ্যাঁ, যে ওরা জুতোই ঠিক করে দেয়। তার মানে শর্ট হয়ে গেছে পা, ওরা জুতো দিয়ে ঠিক করে দেয়। উনি বলতেন জুতোই ঠিক করে দে, হ্যাঁ। তা এই জুতোই ঠিক করে দেওয়া মানে we can adjust the length by adjusting the shoes, but it is not a problem and it's well accepted. All authors that recommended that above 9 years or 10 years you can penetrate the, you can achieve the premature facial closure, but before 9 years you must not do it because adjustment is length is a problem. You can modulate the length later on, or the opposite hip should be addressed. Thank you, sir.
Yes. So generally, I myself uses, I cross one screw and one cross the facial plate and another not cross the facial plate. My second question is also
Right,
you
sir.
and Dr. Romel, in case of non-inguinal neck fracture, avian, does zollinic acid have any role? Any role of zollinic acid in non-inguinal of neck femur by avian?
So far my knowledge, zoledronic acid,
Yes.
it's a bisphosphonate, zoledronic acid, but zolinic commercial name is zolinic. These are the osteoclast inhibitor. These are the drugs we put some osteoporosis patients and other patients. For fracture healing, we will not give it till the fracture heals. So as there is a non-union or there is a avian, once the union has achieved, you can try. But I have no experience. I want to share
May-
Sar's experience.
May I
I
answer,
like
sir?
to share with Sarwar.
So
Romel.
there are, thank you, Ghulam Farooq sir. So there are many journals now saying that, many articles are there. It's saying that zoledronic acid has got many roles in many things, like osteogenesis imperfecta. It is being widely used, second and third generation zoledronic acids, and it is also being used in cases of avian. Things are not established yet to the highest extent, but we can give it, and you can consider the oral forms, and I'm using avian in even in Perthes. These are being widely in India. I mean, among the pediatric orthopedic surgeons. So time will come, and that will say whether this really works. But there are many journals, sir.
Thank you. Thank you very much.
But don't use it in non-union. Non-union and avian.
Avian.
When that is united, then you can.
Then we can try. Yes.
Yes.
Next
Thank you,
question from Dr. Sirajus Salihin. He is asking that what are the causes of pathological fracture in proximal femur in children, and what should be the ideal procedure to manage the pathological fracture in pediatric age group?
I have mentioned in my text, I have mentioned few causes. Most common causes in the pediatric age group, the benign bone tumors like ABC, SBC, fibrous dysplasia. These are the most common causes. Other metabolic bone disease also another causes, like rickets, hyperparathyroidism. These may be the causes, and other causes of osteogenesis imperfecta. These are the causes, common causes. And what are the modalities of treatment? We must be sure about the diagnosis first. We must be sure about the diagnosis, whether it is a benign condition or any malignant condition. We rarely get any fracture in the malignancies like primary malignancy, like osteosarcoma or other conditions. I think Salihin can add to this point. We can unmute him, and the modality is the diagnosis is a must initially. We can do some fresh frozen biopsy, like that of chiroplasty biopsy. If it is a cystic lesion, we can go for fixation. But if it is a doubtful lesion, like that of the less aggressive tumors, giant cell tumors or other tumors, like what is called eosinophilic granuloma, and like this type of lesion in the children frequent, then we have to wait and we have to treat it accordingly. সালিন আছে, সালিন যোগ করতে পারে কিছু?
Thank you, sir. Thank you, sir, for the nice.
সালিন বলো।
Thank you, sir, for
Thank
your elaborated answer. I have add something that pathological fracture is not an emergency. It is not an emergency fracture.
Right, I agree.
You have mentioned all things that first of all we should imaging the whole protocol first. That is
Right.
X-ray, then investigation is local part, MRI or CT scan, and then you have also already mentioned that we have to do must before performing the surgery, must do the biopsy, either core biopsy or incisional biopsy. Then if it is benign, you have mentioned various modalities of treatment, that is you can fix it by DHS or any titanium and elastic nailing in case of simple bone cyst or aneurysm bone cyst, or you can mention that you can fix it either bone graft. And in case of malignant condition, I have also found that we should wait and refer to patient in oncologist and complete the full course of neoadjuvant chemotherapy. Then we
Right.
should perform the surgery. And in case of malignancy, do not go to the tumor, do not touch the tumor, or do not hurry for fixation of the tumor. Thank you, sir.
Thank you. Thank you. Sometimes hip spica had been advised in the benign condition. That
Right.
also heals.
Thank you, sir.
Hip spica only.
Right, sir.
Thank you.
Sir, Professor Shahiduzzaman, sir, can you hear me?
নোমান
হ্যাঁ।
তুমি আগে তোমার চ্যাট বক্সে যে কোয়েশ্চেন আছে ওটা শেষ করো।
Okay, sir.
ওটা শেষ করো, হ্যাঁ, তারপরে তুমি কমেন্ট নেবে।
Next question is from Dr. Shamal Rai. He mentioned that Debnath type fracture 1 is associated more with the AVN of the proximal femur, especially head. He is asking how much risk of AVN increase for every year of age increment, from Dr. Shamal Rai.
Shumon, this is a now debatable subject. Earlier in the books, it was written that if you delay the fixation, if you delay in the trauma from the trauma following surgery 1 day, 2 days, 3 days. Nowadays, it has been written in one of my slides. I have mentioned that in a study they have shown 1 day, 2 day delay doesn't add any complication. Even they have shown that on an average 4.5, 5 days they have done this operation following the type 1 fracture, but they have shown that there is no difference between the incidence of AVN. AVN is a type specific fracture in a complication. Once the trauma causes the trauma causes what is the trauma causing the fracture, that dictates the AVN, what will be happen, how much AVN will happen, and the amount of initial displacement. That is not under your control or my control. That is that unmodifiable factor. And the more proximal the fracture, the more the distal displacement is there, the more chances of AVN. In some books, it has been written 70%. Some books written that it is almost 100%. But on an average, it is for type 1 fracture 38%. In the book, many of the books, it has been mentioned. Thank you, Shuman.
Next question from Dr. Kamruzzaman Khan. He asked, what is the post-spica cast management protocol after pediatric hip fracture? Spica protocol.
Yes. Pediatric hip spica is an adjuvant for all kinds of treatment. Depending on the age, it should be 6 months minimum, maximum 12 months. And depending on the age, not all ages are for, we used to, practically we avoid the baby who are more than 12 years, we don't give hip spica. We try to fix it by rigid fixation and avoid non-weight bearing and keep them non-weight bearing. After removal of the hip spica, we must go for the X-ray. Once the radiology shows that there are some callus formation and the trabecular pattern is restoring, there is no displacement, healing is satisfactory, you can allow the patient weight bearing, but the weight bearing pattern should be gradual weight bearing. Initially, total weight bearing, for 2 to 3 weeks. Then you can allow partial weight bearing. Then after 2 weeks, after almost after removal of the plaster, within 1 month you can allow the patient to work full weight bearing. Thank you, Shamal. Sir,
Another question.
sir, do you want to anything add, sir?
No, no, take it. So it's okay. It is well explained. But after 10 years, it is very difficult to give hip
Keep the
spica.
plaster.
And,
Aesthetic problem is there.
and
Child in
if
female child.
if the child is female, that is another problem. And obese children, hip spica is difficult again.
This is another problem.
But there should be no compromise in reduction. This is very important point. This reduction should be accurate and anatomical as possible. And if the close reduction is not possible, you must be prepared for the open reduction.
Right,
Well. And you must be oriented about this open reduction procedures. This is very important.
Sir,
And
the
hip spica. Question was how much management of the hip spica.
Protocol of hip spica. That was the question, sir.
So hip spica is used 4 to 6 weeks. Usually we keep, if the child is younger, the 4 weeks. If the older child is 6 weeks, and the Shamal says after removal, gradual weight bearing. And but in between, if possible, if the child, in our situation, if the child resides in a very long way, it is not possible to bring him every week to check. But if it is from the Dhaka city, I usually advise them to come for checkup for after a week to see what is the condition after removal of the stitches. And we usually make a window and remove the stitch. And if the plaster is loose, we change the plaster. Rumel, you want to read anything?
Yes, sir. Actually, in Delbet Colonna 1 and 2, hip spica is a must. Whatever the fixation we do, but doesn't matter how much stable it is. But in type 3 and 4, when we are using this pediatric DHS or side screws, side plates, so we can compromise a little with the hip spica. If it is a type 4, it's not that we have to add this hip spica every time. We can use a Petri cast, we can give an abduction bar. That will also prevent this 6, 7, 8 years old boy from getting down in the floor and lying on the bed. So consider it's on the surgeon, I think, that type 1, 2 should be strengthened with spica, but type 3, 4 we can go for compromise and give these things. That will make easy a 10-year, 9-year-old girl to have a abduction bar or a even Petri cast.
Yes, but Rumel, but for the juniors, I will say below 9 years, always give hip spica.
Sir.
There is no compromise.
In the
but
books,
above 9, 10 years,
all books
above
also
9,
mentioned.
Above 9, 10 years, you can compromise, but below 9, 10 years or 9 years of age, always give his spica. That will help, because if there is a non-union, then it's a real problem. Next question.
Next question is from Dr. Kausar Mahmood. It is also related to spica. His question is, which hip spica position is better for the management of proximal femur? Especially he mentioned hip knee 90-90 or hip knee 45-45 or walking spica. Which one is better?
Kausar Mahmood, 1990, there are no mention. Nowhere, 45-45 also no mention. That limb should be in extension. But in case of child, you can adopt 20-degree flexion of the hip. But in case of a older child, the limb should be neutral extension, 20 to 30-degree abduction, and 15-degree internal rotation to keep the position, to keep the reduction, maintain the reduction. There are no scope of giving a 1990 or any 45-45 fixation. Yeah, hip spica position.
These are for the fracture femur, not for the sept of the femur. Next question. Go to the next question.
Next question is from Tahfim Hassan Kobir. He is asking, for the treatment of type 1 proximal femur fracture, how many K-wires should be used, and when should be removed these K-wires? Can these K-wires be kept outside of the skin just for easy removal?
If the child is younger, say it is a child of 3 years, you can keep the K-wires outside, but keeping K-wire outside, there is a problem. We have a lot of experience. If the baby K-wire is kept outside and within a plaster, the baby used to move within the plaster and they move their thighs. So during rubbing, the K-wires may be backed out. And these are the problems. Sometimes the K-wire may go inside if we don't bend the end of the K-wire. So either it is better to keep it inside because you need to keep the healing takes time. It is not that it will take 3 weeks or 4 weeks. Within this time, that K-wire purpose is served. So as the requirement is more than 3 months, a minimum of 3 months for healing is requirement. So you must have to keep the K-wire end inside the soft tissues, and later on you can remove it. And K-wires has another problem. I have mentioned it. Smooth K-wires have a tendency to protrude inside and try to go inside the joint because there are no backup mechanisms. So you can give 2 K-wires in a younger child, but if it is more than 4 years, you can put a threaded screw, 4 millimeter screw with hip spike.
So so next question is from Professor Mehdi Nawaz. He is asking that what may be the ideal technique of placement of hip screw for the fixation of proximal femoral fracture?
This is good. Very good question, Mehdi. Thank you. These are the technical tidbits. It has been written that the screw should be parallel. Otherwise, if you don't put it parallel, if it is diverging or converging, there will be no lag effect. So if there is fracture collapse during healing, there is some amount of collapse and shortening occurs. So if the screws cannot back out by lag effect, there is a healing problem. Non-union can result. So your screws, whether you put 2 screws or 3 screws, it should be parallel to itself, and it should purchase. In the book, it has been written that don't go for any eccentric position or near the cortex, or either anterior cortex or posterior cortex, because in the posterior cortex there are medial circumflex vessels I mentioned. In the anteriorly there are lateral circumflex vessels, retinacular branches. So don't try to pass your guide wires outside the neck. It should be always inside because the bone is stronger. You can position it at the center or at the periphery, but you must not cross it. This is the guideline. And to put the K-wires in the position, I have learned tips from my sir that you use a thicker guide wire. What we use in the DHS fixation in adult, this guide wire is thicker. If you are right in fluoroscopy, you just prick once or you just drill once with a thick guide wire and at your desired position. Then you remove this guide wire and then put the thinner wire, what is allowing the cannulated hip screw. This is a very important trick. So once you can put the thick guide wire and remove it, and within this hole you can put the another thin wire. And every steps you remove 1 wire and keep 2 wires. Then you remove 2nd wire, then keep another wire. In this way, sequentially you can fix it. Sir, can you add, sir, anything?
মেহেদি শোনো, ওই যেটা শ্যামল বললো যে আমাদের যে গাইড ওয়্যার আছে স্ক্রু ফিক্সেশনের জন্য, সেই গাইড ওয়্যার গুলা এত পাতলা যে এগুলা হয় মাঝখানে বেঁকে যায়, যাওয়ার সময় ঠিক মতো যায় না, অথবা যাওয়ার পরে ওইটা ভাঙেও যাইতে পারে। সেই জন্য আমি সবসময় ডিএইচএস এর যে গাইড ওয়্যার আছে, ঠিক গাইড ওয়্যার, সেটাকে খুব কেয়ারফুলি এপিল্যাটারাল দেখে ওটা দিয়ে নিই। 2টা দেওয়ার পরে একটা রিমুভ করে পাতলা গাইড ওয়্যার দিয়ে তারপরে স্ক্রু, তারপরে তোমার ড্রিল করতে হবে ওই পাতলা গাইড ওয়্যারের উপরে। দিস ইজ এ স্মল ট্রিক্স। এগুলো তো আর ওদের বাইরের সিনথেসের গাইড ওয়্যার তো ভালো কোয়ালিটি, কাজে তাদের জন্য ওই ট্রিক্স লাগে না। কিন্তু আমাদের যে গাইডওয়্যার অ্যাভেলেবল সেটা ভিতরে ভাঙিয়ে থেকে যাবে, নাইলে দেখবা বাঁকাইয়া অন্যদিকে চলে গেছে।
না ওই থিক গাইডের স্যার থিক গাইডের উপরে ড্রিল করা যাবে কিনা?
না না ড্রিল করা যাবে না,
থিক গাইডওয়্যার বের করে ওই হোলের মধ্যে চিকনটা দিতে হবে।
চিকনটা দিতে হবে।
হ্যাঁ হ্যাঁ চিকনটা অনায়াসে চলে যায়।
আরেকটা টেকনিক্স হচ্ছে, সেটা হচ্ছে আমার মনে হয় যেটা আমি নিজে করে দেখেছি, ইনফেরিয়র কর্টেক্স দিয়ে যদি একটা প্লেস করা যায়, যদি ঠিক মতো ভাবে সবই যদি একটু হাই আপ না হয়, একটা যদি ইনফেরিয়র কর্টেক্স দিয়ে দেওয়া যায় সেক্ষেত্রে ডিসপ্লেসমেন্ট একটু কম সম্ভাবনা থাকে। আরেকটা হচ্ছে আরেকটা হচ্ছে যদি প্লেসমেন্ট করার ক্ষেত্রে অনেক সময় স্যার আমাদের ঘোরালে, যেটা আগে শ্যামলদা বলছিলেন, অনেক সময় টোটাল হেড সহ ঘুরতে থাকে, তখন আমাদের কি আগে কোনোভাবে এইটাকে হিপ বোনের সাথে, মানে দ্যাট ইজ ইয়ের সাথে কি বলে আমার অ্যাস্টেবুলামের সাথে কোনো
it is not advisable, not even an adult. এটা কেউ কেউ করে আমি জানি, কিন্তু it is not advisable even in adult. হ্যাঁ, তবে তুমি আরেকটা গাইডওয়্যার শোনো, ডিরোটেশন গাইডওয়্যার একটা বা দুইটা এক্সট্রা দিয়ে রাখতে পারো, এবং চিলড্রেনের বেলায় ওইটাই অ্যাডভাইস করা আছে যে মিনিমাম তোমাকে যে গাইডওয়্যার দিয়ে তুমি ড্রিল করতেছো তার উপরে একটা অথবা নিচে একটা গাইডওয়্যার যেন থাকে, which will limit your rotation of the head. কিন্তু অ্যাসিটেবুলামে ফিক্স করা ইভেন ইন অ্যাডাল্ট, তুমি যদি হেডের মাথা পেয়ার্স করে ফেলো, আমরা আজকে অনেকেই করতো, আগে অ্যাভেলেবল স্যাম্বল নেই, অ্যাভেলেবল ছিল না, হেডের মাথা পেয়ার্স করে নিলে আরেকটা অসুবিধা হয় যে দিস ইনক্রিজেস দি চান্স অফ নন ইউনিয়ন, কারণ ওই ছিদ্র দিয়ে সাইনোভিয়াল ফ্লুইড ফ্র্যাকচার সাইডে আসতে পারে। কাজেই একবারেও যেন ফোটা না হয় সেই চেষ্টা করতে হবে। অ্যাক্সিডেন্টালি হয়ে গেলে তো সেটা অন্য জিনিস, কিন্তু তোমাকে গাইডওয়্যার দেওয়ার সময়
স্মুথ কেওয়ারও দিয়ে অ্যাস্টেবুলামে টাচ করা দরকার নেই, তাই তো?
না 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 করা যাবে না, করা উচিত না আর কি। তারপরে যদি কেওয়ার ভেঙে যায়, আমাদের এক্সপেরিয়েন্স আছে যে কেওয়ার ওই অ্যাসিটেবুলাম এবং হেডের মাঝখানে ভেঙে গেছে। হ্যাঁ, তো যাই হোক, এটা অন্য আরেকদিন ডিসকাস করা যাবে। নেক্সট চ্যাট বক্সে আর কি প্রশ্ন আছে?
From Yunus Ali, he is from Rangpur. He is asking about the neck shaft angle in pediatric DHS. What are the angles in neck shaft?
এটা তো শ্যামল বলছে, একবার আবার বলো।
You must have the pelvis X-ray, both including both hips, AP view, and you can measure the normal side. How much angle is there? Because at the age are changing, the neck shaft angle is also changing.
Shamal sir, wo jante chaise DHS set e ki angle ase?
Haan, so
DHS set ta.
So in our hand there are available 120, 125, 130, 35, 40, even 150 degree, up to 50, 150 পর্যন্ত available.
Romel sir, will you add something?
না সেটাই, মানে আসলে কি কি জানতে চাইছে?
হ্যাঁ হ্যাঁ, ওটা अवेलेबल আছে।
120
যেমন অ্যাডাল্টে যেরকম আমরা একটাই অ্যাঙ্গেল পাই, হ্যাঁ, অ্যাডাল্ট ডিএইচএস যেটা আমাদের দেশে পাওয়া যায় 135, কিন্তু চিলড্রেনে ডিফারেন্ট অ্যাঙ্গেলে আছে। তোমাকে ওই যে শ্যামল যেটা বললো ওই ট্রিক্স, অপোজিট হিপের এক্সে নিয়ে অ্যাঙ্গেল মাপে নিতে হবে। হ্যাঁ, প্রিফারেবলি তার উপরেরটা দিতে হবে, যেমন অপোজিট হিপে যদি 125 থাকে পারলে 130টা দেওয়াই ভালো। হ্যাঁ, ছোটটা দেওয়া যাবে না, ছোটটা দেওয়া যাবে না। নেক্সট কোশ্চেন গুলোতে যাও।
Next question is from Dr. Monayam Hussain. He is asking, what will be the protocol of removal of implant, especially time of implant removal in case of pediatric hip fracture management?
This is a great concern. Removal, earlier removal is better. Once the healing is there and concerned surgeon is confident, but it should not be before 6 months. At least 6 months onwards, we can remove the implants, not later than 1 year. So the range is 6 months to 1 year. Within this time, you can remove the implants, all implants, whether union is achieved or not.
Next question is from Dr. Muradul Islam. He is asking, how much parallelism of hip screw should be maintained ideally in the management of proximal femoral fracture? How much parallelism of hip screw should be maintained?
This I have mentioned already. The parallel is a requirement for lag effect to achieve the compression. And once the fracture necrosis and collapse occurs, we should be allow space. Unless you put any back out mechanism, there will be non-linear. So that should be parallel. Once you put it in converging fashion or in diverging fashion, that will not allow you to compress. So that should be parallel. And
parallel is parallel. There is no
distance should be equal in all, at the tip, at the bottom.
Parallelism এর মধ্যে কোনো গ্যাপ নাই যে how much parallelism. Parallel is parallel.
Red line.
Convergent এবং divergent হইতে পারবে না। মানে আইডিয়ালি এখন একটা দেখা গেল যে ফিক্স করার সময় তুমি 5 ডিগ্রি কনভার্জেন্ট হয়ে গেছে, then don't try to
accept করতে হবে।
হ্যাঁ accept করেছে, don't try to do it again and again, কিন্তু try to make it parallel as much as possible. না তুমি আমি নুমান সবগুলো প্রশ্ন শেষ করো, তারপরে ডিসকাশনে আসবে।
Sir, next question is from Professor Alok Bishas. I think this is discussed. His question is, what may be the treatment option for a patient developed AVN due to fracture in proximal femur?
ডিসকাসড হয়ে গেছে, নোমান যেগুলো ডিসকাসড হয়ে যায় সেগুলো দরকার নাই, ছাত্রটা সুন্দর করে বলছেন।
Next question is from Professor Dipankar Nath Talukdar. He is asking, what will be the ideal method of reduction of hip fracture in case of children?
এটাও ডিসকাস হয়ে গেছে, দীপঙ্করের সাথে আলাদা ডিসকাস করা যাবে এটা, কারণ আমাদের জুনিয়রদের প্রশ্নগুলি করো আগে দেখো।
The last question is from Lieutenant Colonel Dr. Kader. He is asking, in case of adolescent, sometimes we get some patients with AVN who had a history of fracture proximal femur. So can you correlate these AVN in adolescent regarding the total hip replacement?
Thank you, Kader. This is the unsolved problem. AVN in the adolescent, this is the unsolved problem. All the efforts we are trying to improve the condition of AVN. Prevention is better, but once AVN is there, we can do very little. But there are some advice. You can advise the patient to avoid weight bearing. You can advise the patient till the AVN consolidates or sclerosis is there and pain subsides. The patient then can be partially weight bearing and gradual weight bearing. These are the non-operative measures. Regarding operative measures, if there is definitive AVN and MRI confirms that the AVN is there, you can go for core decompressions. They have advised also some cancellous bone graft there, and there are vascularized fibular graft they have also. And sometimes if it is not in adolescent, they have not yet advised for any arthroplasty, but arthrodesis they have also advised for that. If there is a arthritis and unremittent pain, you can go for arthrodesis in this case. If provided the other hip is normal, you can offer the patient an arthrodesis, but not the arthroplasty, total hip replacement.
No, arthroplasty is not advisable. Especially in our country, we always, even a stable hip, arthrodesis, we have done lot of, not lot, but few cases of arthrodesis, and patients are very happy if the other hip is normal. Arthrodesis, but the arthroplasty, because after 5-10 years you have to revise, and this is not easy, no? So arthroplasty we will not advise in adolescent, no way. And Deepankar ke unmute karo, dekho, is there any other way?
There is no other question in my chat box, we can unmute.
হ্যাঁ, আনমিউট দীপঙ্কর কে দেখো তো, তার প্রশ্ন কি ছিল যে জানি।
রবি ভাই আপনি
আনমিউট করে দাও দীপঙ্কর। হ্যাঁ, আদার ওয়েজ অফ রিডাকশনে খুব একটা ডেফিনিট আমার জানা নাই। আমরা যেটা reduction, adult and children,
extension, abduction, and then internal rotation. In case of child, it has mentioned that traction can be given in a flexion of the hip.
Okay,
In two books,
there are other
three
5
pet-
ways. Okay, sir, just for academic discussion, I am not asking to embarrass the concerned persons. Only there are 6 ways, either in flexion and extension. Whitman, Leadbetter, Flynn, Watson, Jones, barely.
These are for
There are ways
adults.
to adults and children. Only children, in children, there are 2 ways, either in flexion or extension had been
Or
described.
extension, I mentioned that flexion you can do.
Yeah, okay. Sir, I'd like to point out only two questions. One asked by Professor Ghulam Farooq. Sir, it is written, in case of 14 years of the L fixation, there is no matter, we can cross the QR. But in the early stages, in case of 9 year, it is written in the book, textbook, it is shown in figures. One screw can be passed through the physis. That is, there should be the upper screw, that and not the lower screw. Or in stability concerns, the both the screw can be crossed. Okay, so it is shown in the books. Or another question regarding the avian. Sir, in avian, pediatric hip should be followed up to the 2 years. I have seen in my case, avian, I have seen after 3 years of fixation, bone neck has united well, but avian, focal avian develops in the central part after 3 years. I have two cases. One is focal, one is in the central part.
But 2 years, you followed him on the, then there is no avian.
Yes, sir. In the text, I can show you.
No.
Yes.
The question is whether the avian has developed at 3 years. It was okay at 2 years or
yes,
2.5 years.
Late cases. What is the cause? I don't know.
Late cases. Because we in adult we know that avian can develop even up to
later, 2 years later.
Sir, there is definite evidence of use of intravenous bisphosphonate in the treatment of the avian. So in the text, it has definitely written that in every 6 months it should be followed. In the early case, when it develops early case, if bisphosphonate is used, definitely hold the progress, even it can cure.
না সেটা তো সেটাই বললো তো সেটা রুমেল বলছেই যে আমরা আজকাল ইউজ করতেছি
রুমেল even in parties, but it is written in the avian, post-traumatic avian also.
স্যার আমাদের অনেক সিনিয়র টিচার আছেন, প্রফেসর রিজভি স্যার আছেন, প্রফেসর শহীদুজ্জামান স্যার, কবি স্যার আছেন, বারি স্যার, স্যার ওনাদের কাছ থেকে আমাদের
এখন কমেন্ট নাও,
সামাদ স্যার আছেন স্যার।
রিজভি স্যারকে এত আমরা প্রতিদিন পাই না, দেখো তো রিজভি স্যারকে দেখেন
আসছেন স্যার। ইটস ভেরি উই আর হ্যাপি টু সি ইউ হিয়ার স্যার।
রিজভি স্যারকে আনমিউট করো
স্যার, নিজে আনমিউট করতে পারবেন স্যার।
Yes, thank you. Thank you. It's a pleasure to be with you. Actually, I could not join you.
Happy to see you, sir.
I had some loss of information contact with you, so I'm not very keen in looking Facebook or emails, so I often miss your programs. Anyway, I would like to thank you especially.
Rijvi, every Friday at 8 p.m. Every Friday.
And another problem is
link should be there.
Webinar is nowadays going on.
Yes.
So sometimes this is conflicting. Anyway, it is a great pleasure to listen to Shamal. Shamal has nicely presented. Okay, and this is a big issue in our country, though the proximal femoral fracture is not that common, but since we have a lot of population, we do see enough cases of proximal femoral fractures. And management is tricky, as already been discussed. Management is tricky. Regarding the reduction, I often do not go for this anatomical reduction, but I prefer two important issues to give importance. One is alignment and two is neck shaft angle. If you can reasonably reduce and alignment is good and angle, neck shaft angle is good and you have fixed it nicely. Of course, it has been discussed when you can cross the facial line, when you should not cross, what kind of pins or screws you will use. Shamal has nicely described and has given enough guidelines. Okay, so I prefer two things: alignment and angle.
Except angle.
Other thing is that since it is a pediatric fracture, the healing potential is good, no doubt about that. So with some amount of stepping, it unites. But as we know, in certain age, there are certain kind of blood supply in the head and the neck of the femur. So there are some areas where you should be very careful. Sometimes you may think that open reduction would be easy, but in fact, open reduction is not that easy. And doing that, you might do more damage than helping the baby. And keep always in mind that if you cannot heal these fractures, this is going to be a serious problem. Complications are dangerous. Like if it is a varus angulation or other kind of malunion, it is not a very serious problem, but you can correct it. But if it is a AVN in children, then it is gone. Because the treatment for AVN, though we do sometimes decompression and I do muscle pedicle bone graft, I have a special kind of muscle pedicle bone graft, massage lateralist muscle pedicle bone graft, and I have been using it for quite a long time. I am happy. It's not that bad anyway. But in AVN, if it is AVN, nowadays, you know, even in young adult, we can do replacement surgery. Okay. In my cities, I have done replacement surgery in 18, 19 years as well. Okay. Because fusion of the hip joint is no more a preferred option. So since the total hip replacement has advanced, and if you can do it correctly, the longevity can be expected. At least 15, 20 years longevity is not very difficult to achieve. So,
resurfacing arthroplasty সম্বন্ধে একটু বলেন স্যার।
Resurfacing arthroplasty once was very popular. It came into being and then became a bit popular, but it has lost its popularity because totally replacement give better result than resurfacing arthroplasty. And technically, resurfacing arthroplasty is more difficult than doing a totally replacement. If one can do a totally replacement nicely, and in our situation, we have problem with infection. Other thing, if it is not infected or potentially infected, if we can do it nicely, then we can expect 20 years survival, at least in 90% of the cases. So I would contradict to Professor Ramkwari that the scope for total hip replacement has actually expanded to the adolescent as well and young adult. Okay.
Anyway, young adult. Not adolescent.
Young adult, 18, 19 years, what do you call it? Young adult.
Thank you for the
18 years, Dada? 18 years young adult or it is adolescent?
18 years is young adult.
Young adult. So,
18 years is a child.
Child. So it is anyway.
Up to 18, we say up to 18 is a child.
Yes.
And 18
so,
plus is
I wanted to give emphasis that these proximal femoral fractures should be given much more attention by everyone.
Yes,
okay.
Yes,
and
yes.
if you have difficulty in treating, please take help from these other people.
Yes.
Okay.
Take help from this.
If you feel that you are not very confident, so don't hesitate to ask your senior or somebody else to take advice from. Okay. And always use CM. Never do this kind of operation with CM. And be gentle. Be gentle. Reduction can be done by Whitman procedure or infection as well. But not how many times you try. Not more than 2 times or 3 times. Maximum 3 times. Never go beyond 2-3 times. Then you will do more damage. Okay. fixed nicely. Okay, with these few words, actually there were few other issues I could join, but since there are so many panelists are there or people, senior people are there, I'm stopping here. Thank you very much.
Thank you,
Thanks a lot.
Rilvi. Thanks a lot. We'll get you every Friday, I think. Then
It's okay. I'll try to join you because learning a lot. Since I have not what I could understand listening to Shamal, I joined it bit 10 minutes late, so I missed some part of your lecture. But from your lecture, I learned so I recapitulate so many things because I'm not studying nowadays.
Same to everybody. So you are learning also.
So learning.
Okay.
We are learning, sir, also.
This is the best thing. Young people should study hard. They should present, and not only from books. Okay. Go see the journals. Okay, and provide good enough
latest information
so that we can learn from you. Thank you.
In my chat box, sir, there is a request from Secretary General of Bangladesh Orthopedic Society. He is requesting all of us to attend a webinar on 25th July at 7 p.m. Topic is trauma and orthopedic case management in pandemic situation. His request is from Secretary General of BOSS.
Yes, we know. We are informed.
We know.
Noman, Rafin Hussain has raised his hand. Rafin Hussain. He wants to ask anything. Rafin Hussain.
Rafin Hussain.
Rafin Hussain, can you unmute yourself?
Dr. Rafin Hussain.
Unmute yourself and ask the question. Rafin, you want to ask anything? You have raised your hand. We can see.
I think he is not connected now.
Okay.
I think the question in chat box there are no more questions.
Shahiduzzaman sir.
Shahiduzzaman sir.
Thank you, Debnath.
Thank you, sir.
Shamal, thank you very much for the nice presentation. But you always know that I always prefer presentation. You should not extend more than 30 minutes because it goes beyond that. It is very difficult to keep concentration.
Keep attention.
And I always tell, from less you learn more. Because too many things you cannot learn more. Anyway, it is a good presentation. But you always talked very nicely about all the managements. But I want to mention one thing about Debnath type 4 fracture. If in a young child, you don't need to go for always operation. It is if the child is below 8 years, you can always treat him fairly well by hip spiker.
Right, sir. Thank you. I agree, sir. I agree. Initial traction, 1 or 2 weeks traction followed by hip spiker. That can be enough.
Right. You can try it that hip spiker.
Yes,
and about that, but in fact for fracture 2 you have 3 you have to operate, no doubt about it. But great reduction is very important. You cannot reduce closely, you must have to go for open reduction. Must. And about the AVN, basically the surgeon doesn't have much control. It is the trauma. Actually, it is the trauma, initial trauma, destruction of the blood vessel, which determines actually the course of AVN. And about that replacement, about the total hip in a child, actually, I have seen right. I have seen Professor Learmont doing a total hip in a child of 9 years for rheumatoid arthritis. We are all surprised why you are doing in such a small child. He told me that they have got processes to change. When the child grows, they will change it to a bigger size. But I fully agree. But this is not the condition with us. So we should restrict total hip for our child, our patients, because they cannot go for a second operation and it's not easily available. It's not that easy. Anyway, thank you very much. It was a good learning practice. Well done.
Thank you, sir. Thank you very much.
Dr. Nibir Das, you are raising your hand and you have a question in my chat box also. Dr. Nibir Das, he is asking that how can we manage proximal femoral fracture if we don't have any fracture table?
Let me answer. If you don't have any fracture table and you don't have CM facilities, don't treat.
Don't treat. Okay, try to convince the patient to go to a center where the facilities are available. Okay, and in some of these proximal femoral fractures, okay, can be treated conservatively.
Yeah.
And you must know what are the fractures can be treated conservatively. If you can treat conservatively, treat yourself. If not, send this patient to a center where the facilities are
Available. Yes. Yes. Yes.
Noman, Dr. Wahidur
Yes.
Rahman is raising his hand. Our Secretary General of Orthopedic Society. Wahid Bhai, you want to tell something, sir?
Sir, you can unmute yourself.
Unmute yourself, Wahid Bhai. Unmute, Wahid Bhai.
আচ্ছা রোমেল আমরা শেষ করে নিতে হবে উইদিন 2-3 মিনিটস এটা
Okay, sir.
অলরেডি
আমি একটু বলি শ্যামল
হ্যাঁ শ্যামল
থ্যাংক ইউ
হ্যাঁ।
ফর প্রেজেন্টেশন, গুড প্রেজেন্টেশন। আর আমাদেরকে আমরা শিখতেছি এগুলো, কারণ এখন
Thank you, sir.
রিজভি বললো যেটা রিমাইন্ড হয় তো আমাদের রিক্যাপিচুলেশন হয়। তো এই যে আমাদের চয়েস তো এক্সাক্ট অ্যানাটমিক্যাল অ্যালাইনমেন্ট, এডুকেট ফিক্সেশন এন্ড রেস্টোরেশন অফ ফাংশন। রেস্টোরেশন অফ ফাংশনটা খুব ইম্পর্টেন্ট। তার জন্য আমরা হিপ স্পাইকে কতটুকু দিব না দিব ওটা কিন্তু সার্জন নিজে অনেকটা
Determine করবে।
হ্যাঁ বাড়াইতে পারে, কমাইতে পারে, সেটা আমাদের দেখা যায়। আর একটা জিনিস হলো জোলিন্ড্রোমিক অ্যাসিড, যেমন এক ক্লাসটার শুরুতে একটু কথা বলছিল, আমি অনেক রোগীকে মোর দেন 100 মানে 150 বা তার উপর হইতে পারে দিয়েছি, কিন্তু চিলড্রেনদের বেলায় ফ্র্যাকচার ম্যানেজমেন্টে কোনো এই আছে বলে আমি দেখি নাই। আমি ওটা একটু স্টাডিও করেছিলাম, জার্নাল দেখি নাই, যেটা রোমেলো বোধহয় বললো, এগ্রি করলো। আমরা একটা প্যারাথাইরয়েড, হাইপার প্যারাথাইরয়েড মাল্টিপল ফ্র্যাকচার একটা পেশেন্ট উপায় না দেখে আমরা দিচ্ছিলাম উইথ মেডিকেল বোর্ড কনসালটেশন এন্ড আদার থিং। হাতে কিছুদিন ছিল, 1 বছর ছিল, তারপরে দেখা গেলো যে একটু ইমপ্রুভ করলো, করার হলো না। আলটিমেটলি মাল্টিপল ফ্র্যাকচার হলো প্যারাথাইরয়েড, প্যারাথাইরয়েড বেড করে সার্জারি করা হয়েছিল, অপারেশন করা হয়েছিল, again it recurs, ultimately the patient died of কুমিল্লা ডিস্ট্রিক্ট। এরকম মনে হয়েছে। এই জন্য আমাদের এইটুকু আমার জানা ছিল আর কি, এই বললাম। তো ঠিক আছে, ভালো থাকো তোমরা সবাই। থ্যাংক ইউ। আর
আমাদের
রিজভি
সঙ্গে
ভালো
আমি
আছো?
একটু অ্যাড করি সামার, তোমার সঙ্গে
বলো।
অ্যাড করি জোলোডেনিক অ্যাসিডে। তুমি ঠিকই বলছো যে জোলোডেনিক অ্যাসিড ক্যান বি ইউজড ইন parathyroidism. Hyperparathyroidism can be used in vascular necrosis of femoral head, can be used in certain kind of malignancies, but not for potentiate or accelerate the healing. Rather it will disturb healing. So
healing এর রোল নাই, কিন্তু
yes,
অস্টিওজেনেসিস
healing.
হ্যাঁ, কিন্তু ওই অস্টিওজেনেসিস ইমপারফেক্টটাতে ফ্র্যাকচার প্রিভেন্ট করে আর কি,
কিছুটা করে,
অস্টিওজেনেসিস ইমপারফেক্টটাতে
মানে ওই যে অস্টিওক্লাসিসের কাজটাকে হেল্প করে, আদার কিছু না। তো ঠিক আছে করিদা, থ্যাংক ইউ। হ্যাঁ, সবাইকে ধন্যবাদ আমার পক্ষে।
হ্যাঁ, আমারও মনে হয়
May I speak from Sweden actually?
পার্থ, হ্যাঁ
Shamal is in front of me. Shamal is in front of me, and actually I feel very much actually sorry. I feel very fortunate, very much proud to see him as a presenter. You are my very important student. I am feel very honored, very much grateful to him. I am actually very unblessed person in this discussion, because my friend Professor Rizvi and other Samad Bhai and Professor R.R. Kori and also Shamal, as everybody has been starting Dhaka and running their life service there actually. But in my life, I am unfortunate actually. I passed my life just like Professor Samad Sheikh, whole time outside the Dhaka actually. I am not so lucky. I am unfortunate somewhere actually. I worked with many limitations at Rangpur. It is actually it is the element hour actually Shamal.
তুমি তো গোবরের পদ্ম ফুল।
রিজভি বলো
গোবরের পদ্ম ফুল। রংপুরে ছিলাম পদ্ম ফুল, সিলেটে আসলাম পদ্ম ফুল।
আমাকে এগুলা জয়েন করতে পারি। We please be blessed and fortunate to know, and it is the process of learning to us actually in this old age. And I
পদ্ম ফুল না তো?
হ্যাঁ, আসি ভালো আছে। তুমি কেমন আছো রিজভি?
ফাইন।
ভাবি ভালো তো?
হ্যাঁ, আসি
পার্থ তো গোলাপ ফুল, পার্থ তো পদ্ম ফুল না গোলাপ ফুল।
তুমি ভালোবাসো বেশি তো ভালোবাসার পরিদিবে এই জন্য বলো লাইক দ্যাট Shamal, I am very, very proud. Very, very good. Very nice presentation.
It's a blessing, sir. Blessing for me.
আমার একটা প্রশ্ন, old question to you. I remind one of my grateful, very important teacher to everybody. আমরা যারা সিনিয়র ছিলাম আরার কোরি, আমি
এখন একটা মিটিং এর মধ্যে
সিরাজুল ইসলাম, প্রফেসর সামাদ,
একটা মিটিং এ একটা
হ্যালো, আমরা ক্যাম্প সিরাজুল ইসলাম স্যার একটা কথা বলতেন, those who gets the blood supply from proximal distal, they are prone to have avascular necrosis. এই বহু আগের কথা এটা। Shamal আজকে কথাটা বলতে আমার অনেক I kept that old mementos actually. আর আমার একটা প্রশ্ন হচ্ছে যে এই যে হিস্ট্রিটা দিচ্ছি আমরা, আপনি Shamal কিসে হিস্ট্রিটা করতে গিয়ে কি কি হ্যাজার্ড আপনি ফিল করেছেন আপনি? What hazard? Have you made any paralytic alias or any other problem in his spica? This is my question. Thank you very much for your presentation. Thank you.
I have experienced.
Sorry. I am also grateful to Professor R.R. Kori, who is intimated about the webinar program. Actually, I feel grateful to him. He is my elder brother, and he is a very worthy person to me. Actually, thank you very much.
Sir, may I reply, sir?
Yes.
Bolo.
Sir, I have experienced twice in my life. Twice in my life, abdominal distension and one patient paralytic ileus. One patient abdominal distension post-operatively, sir. I used to do valgus varus osteotomy for Perthes disease. Varus derotation osteotomy, and post-operatively, one patient at the day of operation at night, another on the next day, developed the paralytic ileus. And immediately I opened that plaster and released it and loosened it, and that patient was recovered without any other measures.
What do you think about the cause of this ileus?
It should
my academic question.
My observation is if
now,
you,
what is the cause of the paralytic ileus following hip spica?
Once you don't allow any during hip spica, you must be aware about the bladder swelling. You must about the abdominal space. You must have to put some space, sir.
Shamal, এটা একটা সাইকোসোম্যাটিক বাচ্চাদের এইটাও বলা হয় যে এইভাবে চাপ দিয়ে দিলে তুমি তাকে সেটা it increases the influences over the motility of the gut. এরকম এক সিনিয়র প্রফেসর এরকম বলতেছিল।
Sir, I would like to add, sir.
বলো আমি বলছি
Dr. Wahid is speaking, sir.
কেন ileus হয় এটা বলেন আপনারা।
Sir, this is called, sir, a dynamic paralytic ileus.
Yes, bolo.
This is an dynamic paralytic ileus. The paralytic ileus usually occur due to loss of the potassium. Due to loss of the potassium in the surgical cases, but here, due to some source of the compression and psychosomatic, sir, this is
psychosomatic maybe.
Exactly, psychosomatic. And patient cannot move.
Anyway, I have known.
Please, আপনি বলেন।
Sir, আপনার knowledge টা বলেন, sir.
Actually, I'm adding something to Shamal for your judgment, and Professor R.R. Kori, Professor Izbi, Professor Samad in front of me, every learned person. Actually, during his spica, there is some splagnic nerve implication, which results paralytic ileus. That is actually a study in lovely old book actually, and some of the teacher Alias stuff, Professor Alias study kept his name. It told like this: there is splagnic nerve implication which causing the paralysis. Thank you.
Reflex mechanism.
Reflex, right. Ripankar, he is right. He is reflexly splagnic nerve implication. Thank you.
Thank you.
I'm asking Dr. Saiful Islam. Dr. Saiful Islam, I know you are dealing with all other cases, the pediatric orthopedics cases. Can you evaluate this program? How much effective this program is for the young surgeons, seniors, and like us who are doing pediatric orthopedics? Dr. Saiful Islam.
Thank you. Can you hear me?
Yes, হ্যাঁ
আচ্ছা, আসসালামু আলাইকুম।
সংক্ষেপে বলো।
জি, আসসালামু আলাইকুম। আমাদের আজকের এই সেমিনার ওয়েবিনারের চেয়ারপারসন, উনি আমাদের মেন্টর, আসলে বলতে গেলে মেন্টর অফ দ্য মেন্টর, টিচার অফ দ্য টিচার। বেসিক্যালি আমি কত রিসার্চ স্যারকে পেয়ে, স্যারের বরিশাল মেডিকেলে পেয়ে তারপরে বন্ধুত্ব পেলাম। এনিওয়ে, তো এখন আমি প্রথমে ধন্যবাদ জ্ঞাপন করছি আমাদের সিনিয়র স্যাররা অনেকে আছেন যাদের অক্লান্ত পরিশ্রম এবং চেষ্টায় এবং বাংলাদেশ অর্থোপেডিক্স সোসাইটির নেতৃত্বের চেষ্টায় এই অর্থোপেডিক্স পেডিয়াট্রিক অর্থোপেডিক্সের পোস্ট ক্রিয়েট হয়েছে এবং সেই মধ্যে আমরা ময়মনসিংহ মেডিকেল কলেজে পোস্ট পেয়েছি। এখানে পেডিয়াট্রিক অর্থোপেডিক্স ডিপার্টমেন্ট হয়েছে। এখানে আমাদেরকে একজন সহকারী অধ্যাপক নিয়োগ দেওয়া হয়েছে, ডক্টর খান, তিনি আজকে মডারেটর। আমরা আল্লাহর রহমতে এখানে আমাদের ময়মনসিংহ মেডিকেল কলেজে ফ্র্যাকচার টেবিল আছে, সিআর মাসে, সেই হিসেবে আমরা অনেক কাজ করতে পারছি। তো এর জন্য আমরা ধন্যবাদ জানাচ্ছি পেডিয়াট্রিক অর্থোপেডিক্স সোসাইটির নেতৃবৃন্দকে। আমরা এখানে পার্টিসিপেট করতে পারছি পেডিয়াট্রিক ডিএসএস, ফ্র্যাকচার, তারপরে আমরা টেন্স করছি, আরো অন্যান্য যেগুলো আছে সিপির টেনোটমি করা হচ্ছে। তো এইসব কাজ আমরা করতে পারছি, আশা করি অন্যান্য মেডিকেলেও এটা হবে। আর আজকে যে সেমিনার যার জন্য উৎসর্গিত, আমি কামনা করছি এবং আমি আরেকটা প্রস্তাব দিচ্ছি। উনি এখানে যারা সিনিয়র স্যার আছেন সকলেরই ছাত্র, আমাদের অনেকেরই বড় ভাই, বিশেষ করে আমাদের বরিশাল মেডিকেলের এবং ভাই আছেন, সুমন রায় আছেন, আমাদের ঘনিষ্ঠ ছিলেন, সন্ধানী করতেন। পরবর্তীতে আমাদের যে পোস্টিং অন হবে সেখানে সুনীল ইসলাম বাবু ভাইয়ের নামে কিছু করা যায় কিনা বা সেই কনফারেন্স উৎসর্গিত করা যায় না, এরকম একটা প্রপোজাল জানাচ্ছি। আর এরকম প্রোগ্রাম হওয়াতে আমি এর আগেও একদিন বলেছি স্যার যে আমরা পেরিফেরিতে যারা আমাদের সেন্ট্রালি যখন এরকম কনফারেন্স হয় আমরা সবাই যেতে পারি না। তো এখন এই করোনার কারণে অনেক উপকারও আমরা পাচ্ছি, অনেকে আমরা হারাচ্ছি, অনেকে অসুস্থ হচ্ছে, কিন্তু উপকারও পাওয়া যাচ্ছে। যেমন এই যে একত্রে আমরা এত স্যারকে পাবো একসঙ্গে, তো লার্নেড পার্সন, সিনিয়র পার্সনদেরকে, এটা আমার মনে হয় নিটোর এই প্রোগ্রাম হলে টিএমসি তে হলে আমরা পেতাম না। এনিওয়ে, এটা এর আগেও রংপুর থেকে ইউনুস বলেছিল যে এরকম এটা কন্টিনিউ করুক, দেশ বা বিশ্ব স্বাভাবিক হওয়ার পরও যেন এটা কন্টিনিউ প্রতি সপ্তাহে একবার। আর আমি কৃতজ্ঞতা জানাই আমি পেডিয়াট্রিক অর্থোপেডিক্স সোসাইটির প্রেসিডেন্ট এবং আমাদের সেক্রেটারি জেনারেল রোহন স্যারকে, ওনাদের খবর করতে আমার সৌভাগ্য হয়েছিল ইন্ডিয়ার পুনেতে শিওর সিটি হসপিটালে অল্প সময়ের জন্য বিখ্যাত প্রফেসর সন্দীপ পতওয়ার্তানের সঙ্গে কাজ করেন। এবং আমি ইন্টারন্যাশনাল গতকাল একটা সেমিনারে সিকোতে জয়েন করলাম, ওখানে অবশ্য জোহারির লেকচার শুনলাম। তো আজকের যে লেকচার শুনলাম আমার কোনো অংশে মনে হচ্ছে না আজকের লেকচার সেই ইন্টারন্যাশনাল লেকচার ঠিক খারাপ। আমি ধন্যবাদ জানাচ্ছি স্পিকারকে, মডারেটরকে এবং আমাদের চেয়ারপারসন, সেক্রেটারি জেনারেল এবং আমার সকল স্যার এবং স্যার অফ দ্য স্যারদেরকে ধন্যবাদ।
থ্যাংক ইউ স্যার।
আচ্ছা রুমেল, নোমান, হ্যাঁ শেষ করো, টাইম অনেক, প্রায় 2 ঘন্টা হয়ে গেছে।
থ্যাংক ইউ অল। থ্যাঙ্কস টু চেয়ার, থ্যাঙ্কস টু স্পিকার, থ্যাঙ্কস টু POSB, thanks to Unimed, Uni Health Pharmaceuticals, and definitely to the participants for these. I am inviting.
আচ্ছা রোমেল কোন অ্যানাউন্সমেন্ট থাকলে বলে দাও।
আমাদের নেক্সট আগামী শুক্রবার, প্রতি শুক্রবার যেমন হচ্ছে, আগামী শুক্রবার হচ্ছে ফিমোরাল ফ্র্যাকচার, পেডিয়াট্রিক ফিমোরাল ফ্র্যাকচার, এবং স্পিকার হচ্ছে ডক্টর AKM জহিরুদ্দিন। ডক্টর AKM জহিরুদ্দিন আমাদের ইউএসবির কোষাধ্যক্ষ, উনি আগামী দিনের স্পিকার, and I invite everyone there. আর সাইফুল একটা কথা বলেছিল, ইতিমধ্যেই ইউএসবি এক্সিকিউটিভ কমিটিতে আমাদের সিদ্ধান্ত হয়েছে যে আমাদের নেক্সট বড় যেটা পিওএসবি প্রোগ্রাম হবে, আইফিক্স অথবা পিওএসবি কন, that will be dedicated to Dr. Shamal Islam. That has been already decided.
ঠিক আছে, সবাইকে সিনিয়রদের সবাইকে শুভেচ্ছা। সবাই আছেন, শহীদুজ্জামান আমাদের, হ্যাঁ আমাদ, তারপরে রিজভি, হ্যাঁ আমরা আছি। আমরা আর এখন প্রায় 2 ঘন্টা হয়ে গেছে, আজকে আমরা শেষ করি সবার নিয়ে। আমরা অনেকের বাচ্চা কাচ্চা কান্নাকাটি করতেছে দেখা যায়, শোনা যায়।
বিদ্রোহ করবে।
ঠিক আছে, আজকে সবাইকে ধন্যবাদ। এবং শ্যামল ভালো প্রেজেন্ট করছে, হ্যাঁ যদিও একটু সময় বেশি নিছে, তবে যাই হোক ভালোই প্রেজেন্ট করছে। হ্যাঁ আমরা বলছি যে যেহেতু এটা বা সায়েন্টিফিক মিটিং আমরা ওয়েবিনারে একটু সময় শহীদুজ্জামানও বলতেছিল যে টাইম বেশি হয়ে গেছে, কিন্তু সাবজেক্টটা বড় তো it is well presented. Thank you very much. Thank you Shamal and thank you everybody. Thanks everybody.
Good night to you
Thank you,
all.
sir.
See you
Good
again.
night.
Assalamu alaikum.
Assalamu alaikum.
Thank you. Assalamu alaikum.
Sorry. Assalamu alaikum. Zaman, Kabi. So there are so many people. Anyway,
Thank you.
Joy,
Sir, thank you.
next Friday. তাহলে আসতেই হবে।
Okay.
আচ্ছা ঠিক আছে।
ঈদের আগের দিন কিন্তু স্যার, নেক্সট ফ্রাইডে ঈদের আগের দিন স্যার।
আচ্ছা ঈদের আগের দিন অসুবিধা নাই।